Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the 5th session of the peer learning Periphery to the Fore online case discussion by physicians away from the center. My name is Dr. Rohit Amaravitarna, the moderator of today's event. We know that the physicians working in outstation with limited resources have evolved excellent clinical skills in patient management. So there is a lot to be learned from them. In this year, CCP introduced a new innovation, an online case discussion called Peer Learning Periphery to the Fore to share the knowledge and experiences of physicians who work away from the center. This is bi-monthly session. In this session, 2 physicians present and discuss clinical cases in 1 hour period. Today, we have 2 consultants from Vaunia and Kagod. At the end of the both presentation, we will discuss questions. Please send your questions to Q&A box. Let me to introduce first speaker today, Dr. Ilankumar Bahu Gajanayaka Bahu, consultant physician in internal medicine, DGH, Vaunia. Dr. Ilankumar Bahu Gajanayaka Bahu, MBBS, Jaffna, MD, Colombo, FRACP, Australia, MRCP, UK, FCCP. Overseas training at GVH, Australia. He worked in many hospitals in Sri Lanka as a consultant physician in internal medicine, including DGH Vaunia, Kilinochchi, and NHSL Colombo. He was awarded the Most Innovative Outstation Physician 2011 by Ceylon College of Physicians for his performance as District General Hospital, Kilinochchi. He is going to present on a teenage pregnancy with abnormal head movements. Over to you, Dr. Ilankumar Bahu.
Okay, thank you. Thank you for the Ceylon College of Physicians, and good evening for all, and for the giving this opportunity to share our peripheral experience to the entire country. So now I come back to my main topic. It's a teenage pregnancy with abnormal head movements. This is a case often underdiagnosed in all parts of the country, even in the world. Because if we don't have a low threshold for suspect this problem, we may miss the case, we may lose the patient, even we may lose the baby. So this is the case, 19-year-old girl, P1C0, came to District General Hospital, Vaunia, and period of amenorrhea 20 weeks. And she was admitted to the ETU with epigastric pain, vomiting, dizziness, and syncope 2 to 3 times during last 3 days, and fever for 2 to 3 days, and with some mental state changes also. So a social history, she's a housewife, parents separated. She's living in Vaunia with relatives more than 10 years. Mother is working as a cleaning staff in Colombo more than 10 years. And there's a very good supportive husband. On examination, GCS 15, blood pressure 120/90, and tachycardia, heart rate 120 per minute. Respiratory system within normal limit. Abdomen soft and fundal height, 20 weeks for the period of amenorrhea. And no significant finding in the abdomen or respiratory system. But she had abnormal head movements, on and off abnormal head movements. There's no neck stiffness. There is generalized weakness of all limbs. So what are the possibilities at this stage? This patient came to the emergency department with the fever, little bit of confusion, abnormal head movement, and POA 20 weeks. If there's any possibility of, but there's no neck stiffness. Is it a possibility of viral encephalitis or autoimmune encephalitis or meningoencephalitis or endocarditis or myocarditis with SLE? Or is it a just viral fever with the mental health issues? Usually we think dengue is common in our part of the country and the normal viral fever with her significant social history away from the parents, any mental issues with the simple viral fever. Investigations revealed ECG sinus tachycardia 120 per minute and T inversion V1 to V5. Troponin 29 marginally elevated, white cell count within normal limit but upper limit, and hemoglobin 9.5, platelet 222,000. CRP normal, ESR 30. For the pregnant lady, ESR 30 is normal. And there's a mild derangement of liver function test, mild slightly elevated SGOT 90, SGPT 98, with normal alkaline phosphatase, total protein 6.5, albumin is low, it's 2.9, and globulin 3.6. Renal function normal, sodium 136, and potassium 3.8. And urine, there are 8 to 10 pulses, and the protein base. Case is the typical case in a periphery or in the central hospital, main hospital, somebody coming with multiple complaints. Most of the time, these patients are seen by various specialties. Because of that reason, I just go through this case, the pathway, what was done for her during the admission. So, because of we are suspecting there's a possibility of antiviral meningitis or encephalitis, we commence and in the emergency treatment department, antiviral and antibacterial medications commenced for query viral encephalitis or meningoencephalitis. Because of she had tachycardia, on and off chest pain also she complained, and ECG there are T inversions and marginally raised troponin. So refer to the cardiology team to make sure if there's any possibility of myocarditis in this lady. And 2D echo was done, which was normal, and no evidence of myocarditis or any rheumatic valvular heart disease. And in the meantime, this is the first pregnancy, POA 20 weeks. So she was referred to the gyne obstetric team to make sure if there's any preeclampsia and assess the fetal well-being. But after seeing obstetric team, there are no acute obstetric complications, single viable fetus. So we are happy. The fetus is viable. There's no acute obstetric issues. In the day 2 emergency treatment department, she had bad dreams and some calcinations and delusions. So now, is there any possibility of significant mental health issue for this lady? Teenage pregnancy with the significant social history. So the mental health team seen, they thought there's a possibility of anxiety and severe depression. And during this time, after seeing mental health team, she was transferred to the medical ward. And lumbar puncture was done, this lady, and protein within normal limits, lymphocytes 2, polymorph snail, red blood cell snails, cytology no abnormal cells, and then viral studies were sent, PCR TB also sent. So this LP, it's within the normal limits. The patient had a fever, abnormal behavior, but the LP report is normal. So there's less likely for any viral encephalitis or bacterial meningitis. And in the ward, the 3rd day she fainted and loss of consciousness for less than 1 minute. And she complained bilateral lower limb weakness for 1 day. On and off sudden onset of jerky movements of whole body. In addition to that, she on and off complained abdominal pain also, sometimes chest pain. On examination, lower limbs, there are significant weakness, proximal weakness more than the distal weakness, around 3 out of 5. And dimness reflexes both lower limbs. And bilateral plantar downward sensation normal sensory level. So is it a possibility this patient now has a Guillain-Barré syndrome? Okay, we may think meningoencephalitis, but the LP normal, very, very less likely. Or is it functional? So neurology referral done for this patient. So after neurology team's detailed history and examination, 19 years old pregnant lady, P1C0, period of amenorrhea 20 weeks with multiple complaints, and presented after a fall a day ago following dizziness and blurring of vision. And she had vomiting throughout pregnancy and increased vomiting last 1 month with loss of appetite, poor feeding, constipation. And she has an abnormal behavior for 2 to 3 weeks, less talk, socially isolated, depressed mood, excessive fear, insecurity feelings, but she has good with her husband. And he had mild confusion for last 1 week on and off. And she difficult to work for 1 to 2 weeks due to less energy and global weakness, with bilateral low limb weakness and peripheral numbness. In the meantime, chest and abdominal pain, shortness of breath, palpitation, body weakness, shivering, whole body tremor and head, and blurring of vision. And she was unable to walk for last 3 to 4 days. Now it's bedridden patient. So this patient, young lady, there's no significant past medical history. Now there are so many multiple complaints. On examination, GCS 15, A febrile, heart rate 98, and blood pressure 120/90 with normal respiratory system, but there's a mild tachypnea, respiratory rate 24. Sugar level is 166. She had mild confusion, agitation, on and off fearful appearance, and there's a tachycardia and respiratory system within normal limit, and soft abdomen with the fundus height 20 weeks period of amenorrhea. Cranial examination, including fundus examination, normal, with staring look and multi-directional nystagmus. Upper limb, tone, power, reflex, sensation, normal. Cerebral examination, normal. Lower limb, there are significant findings. Hypertonia, power 3 out of 5, absent bilateral angle jerk and knee jerk with normal sensation, downgoing plantar, difficult to assess the cerebral examination in the lower limb. And she is unable to stand and walk. So there is some abnormality with the gait. So after this examination, we had a video clip. I am going to show you. This video clip was taken with the permission of the patient and the husband, and they are happy to share this video clip with our presentation also. So we got the permission. So this is the patient. She's in the wheelchair, and the face is looking not the normal looking, some fear, and we are checking the nystagmus. And there are some horizontal nystagmus now. There's no ophthalmoplegia and multi-directional nystagmus. When she's looking up also, there's a nystagmus. So she had multi-directional nystagmus. And she's sitting in the wheelchair. So in summary, 9 years old pregnant woman, P1C0 at 20 weeks of gestation with unremarkable past medical history. Started vomiting first weeks of gestation and continued to have severe vomiting, poor feeding, and loss of appetite and loss of weight for last 1 month. Presented with unable to stand and walk, and behavioral abnormality like agitation, and abnormal head movement and feeling of fear and the confusion and other multiple complaints. So examination findings show normal vitals, mild confusion, agitation with head shaking, nystagmus in all directions, and flaccid paralysis of lower limb with normal sensation and the upper limb spared. So what is the possibility now in this case? So this patient has multiple complaints, 20 weeks pregnancy, teenage pregnancy, and significant some neurological findings, multidirectional nystagmus, lower limb weakness, and areflexia. Mental health state is not normal. So is it a brainstem encephalitis? Less likely because the lumbar function is normal. Is there an Guillain-Barré variant with the areflexia, ataxia, some ocular signs? Or is there any other possibility for this case? So because these patients have multiple complaints, not fixed into one system. So this is the case, we have to low threshold for diagnosis. Otherwise, we may delay the treatment. It may affect the prognosis. Wernicke's encephalopathy. So this is the lady, pregnant lady, continuous vomiting for more than 1 month, not eating well, came with some mental state changes, and the nystagmus and ataxia. So this is the clinical diagnosis, Wernicke's encephalopathy. So for this, we can do some other investigations, but it may be difficult in the regional areas as well as it may be difficult in the major hospitals also, timing levels. But it may be helpful, but not necessary to diagnose Wernicke's encephalopathy. And we can do EEG. So we did the EEG. It saw continuous generalized theta slowing with intermittent short runs of delta slowing. And clinically, correlation suggestive for encephalopathy. And the MRI. Okay, because of MRI, we can delay the treatment. But in a regional hospital in Baonia, if we want to do the MRI, we have to contact the teaching hospitals and Radhapura or Yafna. And during the weekends, we can't do. And we had to make sure there's a slot. And this patient has multiple complaints, difficulty in standing. So arranging MRI, we need to do certain steps. Okay, MRI was done 2-3 days after admission. Probably after 1 week, this MRI was done. And there are significant findings in the thalamus area, hyperintense signals in the thalamus area. And periaqueductal area also, there are hyperintense signals in this patient. Wernicke's encephalopathy can affect mammillary bodies also, but in a non-alcoholic patient, it will affect mainly the atypical sites, and the lesions are there, and with the treatment, it will disappear. So we commence the treatment. So IV thiamine 200 milligrams 3 times a daily, and during that time, our hospitals, we don't have the IV thiamine, so the patient brought the IV thiamine from Colombo. Each was nearly 1,000 rupees. They were able to afford only IV thiamine for 3 times a day for 3 days. So after that, we commenced oral thiamine. Thereafter, oral thiamine also not available for some time. So this patient got IV thiamine appropriate time, but possibly inadequate dose. With that, we gave all other vitamin supplements. And the important thing, this patient should be give magnesium if there's a deficiency. Because of thiamine activity, we need magnesium. And after LP report, we stop the acyclovir and the ceftriaxone. So on day 10, this is after treating with the thiamine. After day 10, we took this photo and we can see about the improvements. And this also we got the permission from the patient to show this video clip. She's trying to sit up after 10 days treatment of IV thiamine, but she was able to sit with the support, but it took some time. and the bystander is trying to help her. So we saw the first picture, she was in the wheelchair, unable to stand. But now after 10-day treatment of thiamine, she was able to stand. And the ataxia is still there. So after 3 weeks of oral thiamine, there's markedly improved eye signs, especially in the nystagmus. And improved psychological features, can walk with broad-based gait and reappearance of knee jerk and tremor reduced. So there's a significant clinical improvement after thiamine of 3 weeks. And these are another 2 video clips taken after 3rd week and the 5th weeks of starting thiamine. So I can compare both. So there are left-hand side is the one after 3rd week we did the video, and other one is after 5th week. And the 3rd week, still the face, some depressive features are there. After 6 weeks, she is on the right-hand side with the blue cloth. She is happy. So now this is after 3rd week, she is walking. In the meantime, we can see the after 5th week also. So after 5th week, she was able to walk faster and she is happy and she is steady compared to the 3rd week. So there's a significant difference. Every day there is some improvement with the treatment. So this is, we are now going to check the eye movements, especially looking for nystagmus and any other abnormality. Till there are nystagmus is there, but compared to previous videos, it is less. And the face is very active and she is happy. So Wernicke encephalopathy, now I am going to discuss some theoretical aspects of the Wernicke encephalopathy, because this is the interesting situation, because if we diagnose early, we can treat the patient and we can save the lives. First described by Carl Wernicke in 1881, caused by thiamine deficiency. Often underdiagnosed, recognized condition. Only 50% of cases of Wernicke encephalopathy are diagnosed before death. Only 15% of the cases diagnosed before death. Causes: alcoholism, nutritional deficiencies, hyperemesis gravidarum, intestinal obstructions, bariatric surgery, cancer chemotherapy, hemodialysis, malignant disease. Even anorexia nervosa patients also, they have high chance to develop Wernicke encephalopathy. Effects of thiamine. So now the thiamine deficiency can affect the brain. Thiamine is an important cofactor for several key enzymes in Krebs cycle and transcriptase pentose phosphate pathway. So thiamine deficiency leads to accumulation of toxic intermediates and more lactic acid production. And because of thiamine deficiency, lesions can occur around 3rd and 4th ventricles and the aqueduct. And mainly mammillary bodies involved up to 80% of cases of Wernicke encephalopathy, especially alcoholic patients. Thalamus also involved and associated with the memory loss in Wernicke encephalopathy. There are atypical lesions can occur other areas of the brain, especially in non-alcohol related Wernicke encephalopathy. The clinical tract. This is only present in 10% of the cases. Also, remaining 90% of patients, they don't have this clinical tract. So we can't wait for the clinical tract. Mental state changes, ophthalmoplegia, and ataxia. This is undiagnosed, most often recognized at autopsy. So first, I will come to the encephalopathy. In encephalopathy, most consistent characteristic of the syndrome is change in mental status. Very important, change in mental status in a pregnant lady with a continuous vomiting, we had to suspect wernicke encephalopathy. And there are cognitive changes, and there may be memory impairment and other mental changes also can occur with this thiamine deficiency. And oculophthalmology, the second most common characteristic, and the nystagmus most commonly occur, common ocular abnormality. Complete ophthalmoplegia is very rare. In our case, there's no ophthalmoplegia, but there are significant nystagmus, multidirectional nystagmus. And in addition to that, we can have other neurological features also in wernicke encephalopathy. Ataxia, it may be mild or it may be inability to stand. In our patient, this patient unable to stand. So it's a significant defect, ataxia. But there's no upper limb ataxia. Only it's mainly involving the lower limb. So thiamine deficiency also causes other symptoms, dry beriberi, wet beriberi, and there's a gastrointestinal beriberi also. So dry beriberi, we already know, it's a sensory motor peripheral neuropathy and often lower extremities. Wet beriberi, neuropathy with high output heart failure, present with tachycardia. Our patient had tachycardia for initial 2-3 days, but there are no peripheral edema and on and off chest pain. So peripheral edema may be there, maybe not there. Gastrointestinal beriberi is an interesting area in this case. These patients can come with abdominal pain, vomiting, and lactic acidosis. Because of the vomiting and the abdominal pain, they may admitted into surgical units. Certain cases presenting symptoms had been abdominal pain and lactic acidosis, result in emergency exploratory laparotomy with normal findings. So we need a high index of suspicion. Somebody has persistent vomiting. Is there any possibility of thiamine deficiency? In addition to that, they may have hypothermia or even it can lead to coma if you don't recognize early. So effects on fetus. It can cause miscarriage, intrauterine growth retardation, preterm birth, and peripartum fetus death. So it can affect mother as well as the fetus. Diagnostic challenges. What are the challenges? Wernicke encephalopathy often undiagnosed until after death. One autopsy study reveals this study was done in the autopsy finding patients all have wernicke encephalopathy. But we suspected only 1/3 of alcoholic patients. They have 100 patients have a wernicke encephalopathy, but we suspect only 1/3 of the alcoholic patients when they are alive. In non-alcoholic patients, suspected only 66% of the non-alcoholic patients have wernicke encephalopathy. So there is underdiagnosed. So we need a high index of suspicion. So to attempt to reconcile this diagnostic criteria, in alcoholic patients, they made following suggestion. Out of 4, if they have 2 features, we can think wernicke encephalopathy, like nutritional deficiency, ocular finding, ataxia, or mental state changes. Thiamine level, doing thiamine level, if it is available, it's okay, but we don't need to wait for measuring the thiamine levels or thiamine in the blood results. Biochemical assays are not diagnostic, but it can helpful some in difficult cases to identify the cause. Brain imaging, CT is not reliable. MRI, in wernicke encephalopathy, lesions are seen in 2/3 of the patients. Common finding in MRI, diffusion abnormality around periaqueductal gray area in the 3rd and 4th ventricle and the thalami and the mammillary bodies. So treatment, thiamine. Again, any form of testing should not delay the treatment. Administration of thiamine prevent the progression of wernicke encephalopathy and prevent the reversible deficits of Korsakoff syndrome. There are no consensus on effective dose or route or frequency or duration of treatment. And thiamine half-life is 96 minutes. So it is better give twice daily or thrice daily not single daily dose, because we want to increase the bioavailability. And if we give high dose, there's more diffusion across the blood-brain barrier. European Federation Neurological Society suggests in a Wernicke encephalopathy, this is the treatment. Thiamine 200 milligram 3 times a day with normal saline or dextrose infusion. When we are treating Wernicke encephalopathy, give the thiamine first, then only give the dextrose. And if there's a magnesium deficiency, treat for magnesium deficiency. For prevention, we can give 100 milligram 3 times daily. Response to treatment, there's a good response ocular finding with the treatment, and it is predictable, and the response can occur hours to days. Most cases, horizontal and vertical gaze palsies and ptosis recover completely within days to week. If there is no response with this treatment, suspect if there's any other possibility. And the horizontal nystagmus show dramatic recovery, but it can persist for some time. Ataxia, there's a delayed recovery. Apathy and drowsiness, confusion respond well. There may be a poor recovery with the memory and the learning deficits. So take-home message. What are the take-home message from this case? Often underdiagnosed. Often write-off symptoms are absent. Treatment take priority over diagnosis, and responsive treatment may be diagnostic. Any pregnant lady presented with persistent vomiting and change in mental status, always suspect Wernicke's encephalopathy. Untreated Wernicke encephalopathy leads to coma and death. Prognosis is significantly improved by IV thiamine. As a summary, in our patient, teenage lady came with the POA at 20 weeks, mental state changes, and abnormal behavior, difficulty in walking, and nystagmus in all directions. So it's a clinical diagnosis of Wernicke encephalopathy. After treatment, there's a significant improvement. She survived, and she is now back to closer to normal life. But with the fetus, there's some growth retardation. But at the moment, we had a good outcome because we suspect early and we commence the treatment early. So the take-home message in a pregnant lady, continuous vomiting, there's a mental state status abnormality, always suspect is it Wernicke's encephalopathy. Thank you.
Thank you very much, Dr. Ilankumar Babu, for very interesting, excellent presentation. And we will discuss questions at the end of the next presentation. Please send your questions to Q&A box. Let me just introduce next speaker, Dr. Asanka Nugaliyadda, consultant rheumatologist, DGH Kegor. Dr. Asanka Nugaliyadda, MBBS, MD, overseas training at Department of Rheumatology, Basildon and Thurrock University Hospital, Basildon, UK. She worked in many hospitals in Sri Lanka as a consultant rheumatologist, including DGH Kegor, Matale, Navalapitiya, and Ampara. Over to you, Dr. Asanka.
Thank you, Dr. Rohita. First, I'd like to thank the CCP for giving me this opportunity to present at this forum. So I'm going to present a patient that I have seen while I was at DGH Matale. So this is a 15-year-old girl who presented to the outpatient department with a 2-month history of episodic spontaneous swelling at the back of the neck. So these lumps were of the size of around 3 centimeters. And at the onset, she described a throbbing sort of a pain. And this pain would last for about 3 to 4 days, then would settle, and the lumps would also disappear after some time. At this time, the OPD doctor thought that this is possible lymphadenopathy, and then she was referred to the physician. So when she presented to the physician, at that time she had only one lump at the nape of the neck, and she thought that this was unlikely to be a lymphadenopathy. So she organized an ultrasound scan. It showed a hypoechoic lesion without increased vascularity, but looked benign. But because this unusual presentation, she organized an excision biopsy. So this histology came as showed damaged muscles with fibrosis, with some osteoclast-like giant cells with immature bone formation, which was concluded as myositis ossificans. So with this patient was referred to the orthopedic team. So meanwhile, by the time this girl presented to the orthopedic surgeon, she had developed severe painful swelling of the neck and chest wall. So this had started 2 days following the biopsy. So the orthopedic surgeon arranged an ultrasound scan. It showed inflammatory changes in trapezius, calcaneal anterior, and sternocleidomastoid muscles with subcutaneous edema. He also organized a CT which showed the same changes. So he treated with analgesics and reviewed her, but after a few weeks, she had presented with restricted movements of both shoulders. So at this point, he had referred her to a tertiary orthopedic unit for second opinion, where she underwent a second CT scan, which showed post calcification at the origins of right latissimus dorsi and left serratus anterior muscles. And they thought the findings were in keeping with dystrophic calcification, which that is usually seen after trauma or strain. So there, she was offered a tenotomy with the hope of improving the shoulder mobility, and they had done a repeat biopsy, and she was referred back to Madeleine. So the repeat biopsy showed skeletal muscle tissue with metaplastic cartilage with endochondral ossification, in keeping with myositis ossificans. So with this unusual presentation, this patient was referred to me to exclude any rheumatological condition. So we had a discussion about this patient. So being a rheumatologist, my first thought was whether this is calcinosis cutis associated with autoimmune connective tissue diseases. So we usually see there's a rare entity called Calcinosis Universalis, which is an aggressive form of calcinosis cutis, which can be seen in juvenile dermatomyositis and scleroderma. So that was one possibility. And then we thought that a disorder of calcium metabolism is also possible. And then the other possibility was rare genetic conditions. So few words on Calcinosis Universalis. It's extensive calcinosis cutis. This can be so extensive that it can lead to formation of an exoskeleton. The calcinosis starts from the cutaneous tissue and goes on to involve the deep tissues like fascia and muscle. So this is predominantly seen in extremities and is painful. This is usually seen in dermatomyositis, especially in juvenile dermatomyositis, and also in scleroderma. So this is actually taken from the Lancet. These are pictures from a patient with calcinosis universalis in scleroderma polymyositis overlap syndrome. The histology of this condition is usually dystrophic calcification. There is no ossification, but in very rare cases, there had been some ossification. There was one case report where there was ossification around the pelvis in a patient with scleroderma. But otherwise, the histological findings are mainly dystrophic calcification. So here you can see that there is calcification of the Achilles tendon, and the 3D reconstructed images show calcification of the subcutaneous and underlying deep tissues. So coming back to our patient, she did not have any features to suggest autoimmune connective tissue disease, like she didn't have Raynaud's or sclerodactyly, any features of scleroderma. So her investigations were also normal. That is, yes, the inflammatory markers were normal, CPK was normal, and her ANA was negative. And the histology was not in keeping with calcinosis cutis, so we excluded this diagnosis. So next possibility was a disorder of calcium metabolism, like in pseudo-hypoparathyroidism. The Albright hereditary osteodystrophy can have subcutaneous calcifications, but these patients have this classic clinical features of short stature, round faces, and obesity and short metacarpals, which was not present in our patient. And at this point, we referred her to the endocrinologist also. So she helped us arrange serum PTH levels and vitamin D levels because it was not available at Matale at that point. And the only abnormality with this was that her vitamin D levels were in the insufficient range, but rest the PTH as well as the calcium and phosphate were normal. So the endocrinologist concluded that this cannot be a disorder of calcium metabolism. So we came back to the possibility of rare genetic disorders. So we did some reading and we found two conditions, fibrodysplasia ossificans progressiva and progressive osseous heteroplasia. So a few words on progressive osseous heteroplasia. So in this condition, the ossification starts from the cutaneous tissue and then goes on to involve the deep connective tissues. But in this condition, you don't see this acute painful swellings. It's a chronic progressive one. And of course, I forgot to mention, our patient had this abnormal toes. She had a hallux valgus deformity with malformed first metatarsal joints on both sides. So this progressive osseous heteroplasia did not record any malformations. And in this progressive osseous heteroplasia, the ossification that you see is predominantly intramembranous ossification. But in our patient, what we saw was endochondral ossification. So we thought this was also not possible in our patient. These are pictures showing a patient with progressive osseous heteroplasia. Here the CT shows calcification involving cutaneous tissue and the immediate subcutaneous tissue. Here the involvement is mainly the intermuscular connective tissue rather than the muscles. Here the picture of the skin, it shows induration of, that is due to the calcification of the subcutaneous tissue. But our patient did not have such indurations as well. So we thought the possibility here was fibrodysplasia ossificans progressiva. So this condition is a progressive heterotrophic, this condition is characterized by progressive heterotrophic ossification associated with an inflammatory phase. So there are this characteristic episodic painful soft tissue swelling phase, which is called flare-ups. So it has three phases. First phase is the painful swelling, which lasts from about 1 week to a few weeks. The second phase is a painless induration phase. And the third phase, which occurs about 10 to 12 weeks after the onset, is the ossification phase, where there is ribbon-like ossification of muscles, ligaments, tendons, and aponeurosis. So these flares often starts with the neck, back, and the shoulders, and the flare-ups are triggered by injury, viral infections, surgical procedures, muscle stretching, and intramuscular injections. So these patients have this characteristic morphological features. So almost all patients have this hallux valgus deformity due to malformed metatarsals and fused interphalangeals. So our patient had this. And they also have short malformed thumbs and clinodactyly, neck stiffness, and hearing loss. So with the given history of spontaneous myositis ossificans at multiple sites without a history of previous significant trauma, and the characteristic flare-ups and the presence of the characteristic bilateral hallux valgus deformity, we diagnosed fibrodysplasia ossificans progressiva in our patient. So we, at this time, about 5 months have elapsed. So we did a repeat CT scan with 3D reconstruction. So it showed extensive longitudinal calcifications, ossifications in bilateral latissimus dorsi, serratus anterior, serratus posterior inferior, erectus spinae, capitis, and quadratus lumborum muscles. So this was in keeping with the diagnosis of fibrodysplasia ossificans progressiva. So we also referred this patient to a senior rheumatologist at NHSL. So she also agreed with the diagnosis and management plan. So a few words on this condition. So it is also called myositis ossificans progressiva, or the stone man disease, or the Munch-Myers disease. It's a rare connective tissue disorder. The prevalence is about 1 in 2 million. It's a heritable disease inherited in an autosomal dominant pattern. Most of the cases are, though it is inherited, most of the cases are sporadic. It is caused by a mutation in a gene encoding a bone morphogenetic protein type 1 receptor. So I've discussed about the flare-ups earlier, and this ossification can progress it can span across joints. So this leads to a limited mobility. So involvement of the rib cage will result in respiratory insufficiency, but they will have the diaphragmatic breathing. It will be spared. So this picture here shows this extensive involvement, which has caused this abnormal scoliosis and the sort of calcification is extending all across this patient's chest wall. So the TMJ joints can also get involved. It's frequently involved in this condition, which can lead to starvation because the mouth opening will be involved. So the life expectancy is usually around 40 years. So the diagnosis is usually made by the clinical features with classic flare-ups, followed by ribbon-like heterotrophic ossification, and the morphological features with this hallux deformity and the malformation of metatarsophalangeal first metatarsophalangeal joints, and then genetic testing if possible. So management, there is no actual definite management for this condition. So there is an international clinical council on fibrodysplasia ossificans progressiva who have looked into the case series and reports and had made some recommendations. So COX-2 inhibitors initially was thought to reduce the progression, but however now it is beneficial only to relieve the pain. So that is recommended. So to prevent acute attacks and to manage the acute attacks, prednisolone had been useful. So 1 to 2 milligrams per kg per day, up to a maximum of 100 milligrams for 3 to 4 days, to be started within the first 24 hours of the acute attack. And then we can use prednisolone as prophylaxis as well. That is prednisolone 1 to 2 milligrams per kg per day for 3 days following surgeries and dental procedures and blunt trauma. So bisphosphonates, there are some case reports suggesting some improvement or alleviation of symptoms with bisphosphonate. So pamidronate had been used 1 milligram per kg per day for 3 days for children about 3 years, and 0.5 milligram per kg per day for 3 days for children below 3 years. And bisphosphonates also have a place in prevention of bone loss due to recurrent steroid use. Mast cell stabilizers are thought to be helpful, but there is no definite place at the moment, but may be beneficial. Formalin had been used in some cases, and now imatinib is being tried out. So the main important thing is prevention of flares. So we have to educate the patients about avoiding unnecessary surgical procedures, trauma, and IM injections. And we have to prevent infections, especially viral infections. So timely vaccination is important. And we have to prevent muscle stretching. Passive stretching should be avoided. Oral hygiene is important because bad oral hygiene will lead to TMJ joint involvement and later on affect the jaw mobility. And these patients can have deafness, so we have to screen for deafness. And of course, mental well-being is also important because this is actually a very depressing condition because of the disability. The patients will end up in severe disability. So the mental well-being is important, so psychological support is needed, and occupational therapy is needed because these people will need assistive devices. And physiotherapy, main thing is should avoid passive stretching. Gentle physiotherapy can be used to alleviate the symptoms of acute flares like heat and cold therapy. So what we did for our patient is we gave her celecoxib 100 milligram twice daily to help her with the pain. And we gave her prednisolone 1 milligram per kg per day for 4 days for her flares. And with the help of the endocrinologist, we corrected her vitamin D insufficiency with oral vitamin D because IM injections are contraindicated in these patients. And we had to give IV pramidronate for one episode where it was resistant for steroids. So we gave one IV pramidronate 1 milligram per kg per day for 3 days, which helped her with an acute flare. And we also referred her for occupational therapy because she had restricted shoulder movements bilaterally, so it was affecting her activities of daily living. And then the problem was with COVID vaccine because it's an IM vaccine. So we discussed with the virologist, and he said that it can be administered subcutaneously. So we offered her subcutaneous COVID vaccine. So after 1 year, she had bilateral shoulder joint restricted movements and 3 flares during that year. So the take-home message is we have to consider the possibility of fibrodysplasia ossificans progressiva in children or young patients presenting with heterotrophic ossifications and look for the characteristic morphological features. And then if in the presence of these, we have to avoid unnecessary surgical procedures and repeat biopsies. Thank you.
Thank you, Dr. Asanga, for very interesting and informative presentation on a young girl with heterotrophic ossification. And as there are no questions in the Q&A box, may I ask a question from Dr. Vahu? And referring to your patient, what is the duration of thiamine therapy for your patient in pregnancy? How long you want?
Yeah, it's a good question, because if you are treating for wernickeencephaly, there are no definite guidelines. But the European Society guideline is giving 200 milligram IV thiamine 3 times a day, IV thiamine. If they are having a good significant response, then your diagnosis is clear. But they are telling you keep on giving thiamine and assess the symptoms. And assess the symptoms. After some time, if you think there are no improvement of symptoms, okay, after 3 months you are giving IV thiamine, now you have follow up the patients, there are no improvement symptoms like nystagmus or other symptoms are now static, there's no improvement, then you can consider this patient go for a preventive therapy. So basically I am recommending, okay, we are giving thiamine and assessing the symptoms. If the symptoms are resolved and you are continuing the treatment, and after some time you are realizing, okay, after 1 month there's no improvement, then you can go for the preventive dose, 100 milligram 3 times daily. But there are no clear guidelines how long you should give the thiamine. There's no guideline thiamine. So it's the base, because it's a water-soluble vitamin. So there is no harm we can give throughout the pregnancy, because we can prevent the fetus and the mother. So then we go for the oral, but there's no clear guidance how long we should continue this thiamine.
Okay. Thank you very much, Dr. Vahu. And Dr. Asanga, can I ask a question from you? Actually, your patient mostly seen by surgeons and orthopedic surgeons.
Yes.
So, as you suggested, the flare-up is probably due to surgical intervention.
Yes.
So I think there may be a number of flare-up probably due to surgical intervention in your patient.
Yes, of course, that's the thing. So most of the case reports also said that reported that most of these patients had at least 2 or 3 biopsies, because this condition is very rare. It is not considered, so that is a problem. So the surgical, because surgical procedures can precipitate and aggravate the ossification, but unfortunately, most of these patients, by the time of the diagnosis, had about 2 to 3 biopsies.
Yes, okay. Thank you very much, Dr. Asanga. Very interesting presentation. And so, in the absence of any more questions, let me wind up the sessions today now. And first, I would like to thank two speakers, Dr. Asanga Nugaliad and Dr. Ilankuma Bahu, for accepting our invitation and their excellent presentations. And also, I would like to thank CCP staff, audiovisual team, Mr. Nalina, and sponsor, Merck Pharmaceutical, for their continuous support, and all virtual participants who are joining with us. Next session of peer learning Periphery to Fore will be held on 14 December 2022. Thank you very much.